good evening to all the Telangana TS IAVDL members. On behalf of TS IAVDL 2022 team, I cordially invite all the members for today's webinar on the clinical topic Hidradenitis suppurativa, a most difficult to treat clinical condition. That is today, 29th May 2022 from 5 p.m. to 7 p.m. A brief introduction about this program. It will start with the pathogenesis of hidradenitis suppurativa by Dr. Poorna Chandra, professor at ESI Medical College, followed by medical and surgical management of hidradenitis suppurativa by Dr. Sharmila Patel Madam. She is a professor and head at DY Patil Medical College, Mumbai, followed by panel discussion, which will be moderated by Dr. V. Anand Kumar, senior consultant dermatologist at KIMS Hospital. The panelists will be Dr. Parthasarthi sir, senior consultant dermatologist at Ansala Skin Institute, Dr. Sharmila Patil, professor and head, DY Patil Medical College, Mumbai, Dr. Poorna Chandra, professor, ESI Medical College, Hyderabad, Dr. Kavita, associate professor at Jagityal Medical College, which will be followed by vote of thanks by our treasurer, Dr. Satyasri Madam. So I welcome the chairpersons for today's webinar session, Dr. Rajalakshmi Madam. She is senior consultant dermatologist at Apollo Hospital, Secunderabad, and Dr. Indra Madam, professor at Osmania Medical College. So I hand over to chairpersons to start the proceedings, and I request all the faculty to maintain the time. Thank you, madam. Over to chairpersons.
I thank TSIADVL for giving us the opportunity to chair the session. We now start the session. The first session is on pathogenesis of hidradenitis suppurativa. This will be delivered by Dr. Poorna Chandra, who is professor of ESI Medical College, Erragadda, Hyderabad. And I invite Dr. Poorna Chandra to start her lecture.
Hello, good evening, everyone. On the outset, I thank TSIADVL organization for giving me the opportunity to talk on this session. So I just go on to the pathogenesis first. The exact etiology of HS is still unproven. In the last few years, numerous studies hypothesize that the disease is triggered by genetic and environmental factors. So the importance of genetic factors is highlighted by studies showing that 30 to 40% of HS patients reported a family history of HS. Moreover, familial forms of HS following an autosomal pattern of inheritance with 100% penetrance has been described in different populations. And the concept was proposed that HS is an autoinflammatory disease characterized by dysregulation of gamma secretase and Notch pathway. So the appropriate Notch signaling is of importance for appropriate maintenance of the inner and outer root sheath homeostasis. So any deficiency of this Notch signaling pathway results in the conversion of hair follicles into keratin-enriched epidermal cysts, which compromises the apocrine gland homeostasis and leads to the stimulation of toll-like receptor-mediated innate immunity, supporting and maintaining the chronic inflammation. And apart from these mutations, there are further studies stating that there are some genes, that is one of these genes is MEFP encodes the pattern recognition receptor, that is pyrin, a critical component of the inflammasome system, and activation of this inflammasome leads to the production of interleukin-1 beta, that is a cytokine with an important role in HS pathogenesis. However, extensive studies are needed for this. So the other things are environmental factors. So the environmental factors and or lifestyle factors, that is obesity, smoking, and skin occlusion. There are two major lifestyle factors, that is obesity and smoking. So that central obesity, which is considered as one of the metabolic syndrome, that is apart from hyperglycemia, dyslipidemia, and hypertension, it is considered as obesity favors the HS in two ways. That is, one is it enlarges the skin folds in the body and consequently increases the mechanical stress, maceration, and anaerobic conditions within these folds. And secondly, the obesity also induces subclinical inflammation in the adipose tissue with secretion of inflammatory cytokines, that is interleukin-1 beta and tumor necrotic factor alpha, which can reach the skin from the underlying subcutaneous tissue or via the blood flow. So the maceration I was telling, that skin folds that is mostly in the axillary, inguinal, genital, gluteal and perianal area contain a high density of pilosebaceous apocrine units, and they further differ from other body areas by high temperature and moisture. So this leads to increased microbiome composition that is normal. It differs from other normal flora by increased predominant flora that will be present will be gram-positive aerobic and facultative anaerobic, such as Coagulase negative Staphylococcus species, Corynebacterium species, and Propionibacterium acne with a low abundance. Sometimes there are gram-negative anaerobes such as Privotella, which are typical for mucosal sites, were also detected in low numbers. And these Privotella and other anaerobes and decreased abundance of normal species, that is Staphylococcus epidermidis. And pathogenetically, these resident anaerobic bacteria may support the initial hair follicle inflammation in Hs. So other factors that are being important here is in intertriginous area, there is mechanical maceration that induces micro injuries in the skin that releases damaged associated molecules, otherwise called alarmins, and this cutaneous entry of these microbial components. And these damage associated molecular proteins are the nucleic acid and heat shock proteins. So these components, they stimulate local macrophages and dendritic cells, and they produce inflammatory cytokines. And the bacterial components are also recognized by, and they activate the complement pathway. So the other organisms that are said to be present in the intertriginous areas is Staphylococcus lugdunensis, associated with acute mild Hs nodules, and Fusobacterium, that is associated with the chronic severe Hs. So this proves that some antibiotic can also help in the treatment of Hs. So and one more thing here is, it should be noted that Hs lesions can also develop in intertriginous areas that do not bear the apocrine glands, such as submammary folds. These apocrine glands do not appear to be necessary for the development of Hs lesions, and inflammation of these glands was demonstrated to be a secondary phenomenon. So apart from obesity, so smoking also helps, also it acts as a triggering factor for Hs. That is, smoking, it is very common among patients with Hs, and reports say that 90% of the patients are currently smoking or formerly smoking, they develop Hs. They have chances of developing Hs. That is, that in that the nicotine may produce epidermal hyperplasia and dysbiosis. In monocytic cells, especially when exposed to bacterial components, nicotine may increase intracellular cyclic AMP levels and strengthen the protection of interleukin-10. That is the cytokine that plays an important role in Hs. So apart from the other things, are insulin resistance. It also alters the growth of keratinocytes, inducing endothelial activation and chemokine production. And inflammatory cytokines provoke the infiltration of immune cells from the blood, supporting the inflammatory process of the skin. So apart from these environmental factors, that is obesity, smoking and skin occlusion, so there are sex hormones have also been suspected, and this is based on the frequently observed onset of the Hs after puberty and the decreased disease severity during pregnancy. In female patients, efficacy of anti-androgens is suggested actually. So this is already I told you. So this is insulin resistance and gamma secretase complex alterations, obesity, mechanical stress, and nicotine. All these play a role in the Hs predisposing factor. Next slide, please. So here there are so many cytokines that are involved. There is, first is occlusion of the dilatation of this is caused by the predisposing factors, that is disease predisposing factors. They induce perifollicular immune activation as well as occlusion and leads to sebum stasis and dilatation of the hair follicles. This leads to the growth of the bacteria within the occluded hair follicles and release of damage associated molecules, which stimulate local immune cells, especially macrophages, to produce inflammatory cytokines like tumor necrotic factor alpha and interleukin-1 beta via epithelium activating and chemokine inducing properties. So these cytokines, they provoke the infiltration of various immune cell populations, that is neutrophil granulocytes, monocytes, into the hair follicle units. So there is epidermal proliferation and epidermal production of antimicrobial proteins. So is too low to confine cutaneous bacterial overgrowth. These neutrophil granulocytes, whose infiltration is supported by chemokines, are important phagocytes, but they are also producers of pro-inflammatory cytokines. These cells also form neutrophil extracellular traps, which can inhibit bacterial growth, but they also favor the autoimmune features. So the infiltrated B cells and plasma cells produce antibodies and may contribute to the activation of the complement system. And the secreted proteolytic enzymes may further increase the fragility of the basement membrane zone and causes follicular rupture and release of the contents into the dermis, and that triggers the inflammation. So there is bacterial growth further boosts up the inflammation. The inflammatory process of hair follicles with pus formation, epithelialization within the disintegrated tissue, and abundance of extracellular matrix degrading enzymes, that is matrix metalloproteinases, finally lead to the formation of pus draining epithelial strands. So that is, and destruction of the skin architecture. And there is self-amplifying inflammatory pathways that involve further cytokines, and that leads to recurrent and chronicity of the HS. So, I conclude by saying that there are so many cytokines that are involved. So I conclude here that it is a complex immunologically mediated disease that involves different components simultaneously. That is inflammasome-driven innate component with dominance of neutrophilic granulocytes, and a significant anti-inflammatory component and strong activation of Th1 and Th17 pathways, but not Th22. So that is important. So Th17 and Th1. So the anaerobic bacteria and cell damage associated molecules play an important triggering role. Activated pathways induce inflammatory vicious circles, including resulting in pain, purulence, and tissue destruction and scarring. So there are several clinical studies that are being carried out to prevent the action of these cytokines, that is mainly interleukin 17, interleukin 1. So that is this pathogenic, not only the pathogenic complexity, but also the destructive nature of the HS presents a challenge for the development of therapeutic approaches for the disease. In fact, once the skin architecture is damaged, it cannot be repaired with medications. So therefore, great efforts are needed to reduce the current intolerable delay in the diagnosis of HS. That is a prerequisite for early start of anti-inflammatory treatment. And early treatment may also prevent the to counteract morbidities and reduce life expectancy for the patients with HS. Thank you so much, and I thank my departmental PGs and staff for collecting the material for this HS. Thank you so much.
Thank you, Purnachandra, for that lucid presentation of pathogenesis of hidradenitis suppurativa, which is very important to understand the management, like especially with the advent of these biologics, we should understand the pathogenesis. Next, we will move on to the next talk. I hand over the mic to Dr. Rajalakshmi Madam.
Thank you, Indra ma'am, for the nice words about the first speaker. And also now I'll be introducing Dr. Sharmila Patil, where all of you know about her. She is professor and head of the Department of Dermatology, Dr. D.Y. Patil Medical College Hospital, Mumbai. She has 51 publications and 67 presentations to her credit. She was Honorary Secretary General Maharashtra in 2018-2020, and then Medical Education Unit Coordinator in the college. And she has edited many books like Window to Psoriasis, Atlas of Dermatoscopy, DY Survival Guide for Postgraduate Students. Her areas of interest: vitiligo, psoriasis, then HS and dermatoscopy. And we have heard a lot of all these things from Sharmila ma'am. And today we are fortunate enough to have her in today's lecture. She'll be telling about medical and surgical management of HS. Ma'am, we want to hear more about HS, which is very difficult topic and very difficult to treat also. So over to Dr. Sharmila Patil. Please, ma'am.
Thank you, madam, for such a kind introduction. And at the outset, I would like to thank IAVDL Telangana for giving me an opportunity to share my views and my experiences, which I am really very, interested in sharing, and whether it is useful in treating such difficult disease. Why it is very important to understand the pathogenesis, because the treatment depends on what is the pathogenesis process. And as we have seen from the past lecture, It is very challenging and it's a complex pathogenesis, starting from the genetic material to the inflammatory cell. And there's no definitive cure is lacking for HS. And the management, normally what we do is the symptomatic, which remains challenging due to the relapsing and the remitting nature of the disease. So I have no conflict of interest in this topic. And hidradenitis suppurativa, as we know, it's a condition where the patient starts presenting by the post-pubertal age group with the painful eruptions and the malodorous discharge. So that's a time where the young adolescent child is facing with this difficult chronic condition. Now, it is very many times it is often misdiagnosed, and the diagnosis may be delayed for the years together that finally is labeled as HS. Once we are diagnosed, it is very resistant to both medical and surgical management, and the pain impairs the function of the person, especially if it is in the groin and the axilla, and it finally leads to poor quality of life and frustration and depression to both the consultant as well as to the patient. There's a lot of disease burden in HS because the early age of onset, though, as Madam said in the past lecture, the obesity, smoking, family history, associated comorbid conditions like Crohn's disease or PCOS also adds agony to the pain. There's a lot of social stigma and psychological impact. I remember one person who always said that he used to choose the darkest of the dark color shirts because when he used to go for the meeting, he used to be always scared whether there'll be a stain which will be seen in the axilla on the clothes. And the work disability and financial burden, obviously, because it's a chronic disease. We all know these are the stages of the HS where, stage 1, where you see a single lesion, which is nodular or it could be an abscess. As the disease progresses from stage 1 to stage 2, we start getting multiple such painful deep-seated nodular lesions with sinuses, but the intercurrent skin is normal. And finally, a stage 3 where the patient has got all the entire skin get affected with interconnecting deep-rooted sinuses which are coming together. There is no fever in this condition, and the patient may have the associated like acne, or there may be a comedones which will be there. Now, these are the other comorbid conditions which we see normally with the patients, like an obesity, acanthosis nigricans, as metabolic syndrome is associated. So look for hypertension, dyslipidemia, thyroid disorders, spondyloarthropathy, psychiatric disorders, or Crohn's disease. Many times are associated with it. Clinical pictures is actually, it's a disease with a chronicity with mean duration of 18.8 years. The milder forms of the disease are seen in 2/3 of the cases. The intermediates are seen in the 1/4 and severe are 1/5. So this 1/5 are the people, first of all, the prevalence of disease is very low, like 0.003%. And of that 1/5 is the other cases which are severe. But if you don't target them in the earlier stages to treat it, diagnosis properly, it is going to progress. And the natural progression between the stages is not defined, and the old age disease is very rare. So it is always mandatory, since we know it's a disease which can present to any department, like a gynecology patient can go with PCOS with multiple boils, or there could be the flare-up during pregnancy, or a male patient may have lesions in the axilla or the groin. So these are the areas where different patient can be visiting many times. What we have seen, patients is visited to the plastic surgeon, or if patient is visited to the gastroenterologist for the Crohn's or the abdominal complaints. And the dermatologists and rheumatologists are the ones who should pick up the disease as early as possible. Now, clinical features I have not covered in this, but actually we all know the clinical features are the multiple deep-seated sinuses and the painful abscesses over the period of years. And when we see any patient who has got multiple sinuses or the discharging regions or the nodules which are there, the most important role is the bacteria we have to rule out. So we should do the microbiology study. So taking a swab from the exudate and the tissue is mandatory so that we understand the organisms which are there. It could be polymicrobial. And taking a histopathology also, if it is required, we should go ahead in the chronic diseases, because any chronic disease can sometimes have an underlying malignancy also. The most important part when we are treating the patient is doing either a sinogram or sonography or the MRI. This is very important because when we do the sinogram or the sonography, we get an idea about how deep is the infection or the inflammation. And then after treatment or after a year, we can always assess the lesions, how effective is our treatment. Then it is always mandatory for the preoperative planning, because these are these conditions where we can anytime require surgical intervention. So preoperative investigations, if you are planning for, so we have to do CBC, proteins, PRP, and mainly for the metabolic syndrome, we should always look for lipid, dyslipidemia is commonly associated, the fasting insulin levels, and whatever other parameters which are required. G6PD we do because if pentapsone is a drug of choice, if you want to add as an adjuvant in the therapy. So these are the various differential diagnoses. When the patient is in the early stage, it is to be simple furuncle, carbuncle, acne conglobata, infected epidermoid sheath, cellulitis, or blastomycosis. In the early stage, whenever you see furuncle in the axilla or the groin, always ask the patient to follow up in your OPD and see that, and give him an idea that lesions, if it recurs more often, then kindly recommend the patient that you need to take the treatment for the longer period. And as the disease stage into the stage 2 or stage 3, it could be tuberculous abscesses. Because in my practice, I have seen those patients who are mainly treated by the physicians or with the surgeons as a case of tuberculosis. The awareness about HS is not there with the surgeons. Actinomycosis, yes, a very good differential diagnosis. Crohn's disease, specifically, it is combined when the patient has got perianal or the vaginal lesions. The Crohn's disease is one of the closest differential diagnoses. But in the Crohn's disease, the condition is highly edematous and lot of mucosal involvement is there. Pyeloneedle cyanosis is many times associated with the HS, the cat scratch disease, granular inguinale, LGB, and nodulo-ulcerative lesions of syphilis also may mimic sometimes. So these are the articles which is published in British Journal of Dermatology, where they are focused on the current and the future treatment of hidradenitis suppurativa. And most of the time, what the treatment, another recent article which is published in 2022. So these are the two articles which are mostly the recent advances of understanding and managing the HS, where I have gone through it to guide and the management to decide HS. The goal of the treatment is, as we know, there's a lot of inflammation. So we want to reduce the formation of a new inflammatory lesions, sinus tract and scarring. Second is to treat the existing lesions and the symptoms. And third is to minimize the associated psychological morbidity. We have to be constantly with the patient in the journey of a disease, because these are the people who are suffered having severe quality of life affects is deteriorated. So we need to be always there to support them during the journey of a treatment. Maybe it could be a year or two. The various medical management treatment drugs which are often mentioned in the article or the journals and are the various lines like tetracycline, clindamycin, OCPs. So depending on when you observe the patient, the first line should be a tetracycline or doxycycline to be used for at least 12 weeks. That is what I want to focus. When you see a patient of a grade 1, always see that you treat the patient adequately and give the emphasis that treatment has to be taken minimum for 2 to 3 months. Otherwise, there are chances of recurrences. And then the patient's inflammation keeps on continuing and the disease keeps on spreading. Then once if the patient is a second drug of choice could be clindamycin and rifampicin. If it is resistant to tetra or doxy, patient has not responded, we can start clindamycin 300 and the rifampicin 300 BD, second line of therapy for mild to moderate HS. Again, here the focus is for 12 weeks. Don't stop the treatment unless the patient has got having a good remission. Oral contraceptives, if required, if the patient has a disease which has a flare-up which related with the menstrual cycle. Spironolactone, I have not used up till now. Finasteride also has been, but there are only limited reports which are there. Metformin, yes, if the patient has got associated comorbid condition and obesity, it is to be given 500 milligrams either 2 times a day or 3 times a day. It is very effective in controlling the weight and to control the hyperinsulinemia. Isotretinoin, acetretin is a good drug. Isotretinoin doesn't work. So isotretinoin, if you want to start, if patient has got associated acne conglobata or the lot of follicular occlusion is seen. Prednisolone is a double-edged weapon because you can give it and the patient may have flare-up. So certain studies have proved using a low dose of steroid can be helpful. And yes, the adalimumab is the drug which I find is very effective, and we should get used to this molecule using more and more frequently when it is a stage 2 and 3 of the hidradenitis suppurativa, because this is a drug which has made a tremendous difference in the patient's quality of life. Either you can, depending on the weight of the patient, the doses are to be modified, and I will discuss it with you further. Infliximab is used, but it is not effective as the adalimumab. So when we think of doing a recommendations for the treatment of hidradenitis suppurativa, the most important is the lifestyle modification and general treatment, because the obesity and smoking, two important factors. But the smoking is not much as common a precipitating factor in India, but the obesity, yes, now we are seeing people. And most the advice what we give to the patients in all the 3 stages is cessation of smoking if they are smokers, reduce the body weight, advise wearing loose clothing to avoid friction with the skin, and use of an antiseptic wash to keep the skin clean and to reduce the oral odor which is there, and refer if required a psychological support, or we ourselves are a better psychological support to the patient than anybody else. And the pain management is another very important aspect of a treatment in all the 3 stages. So when we think of stage 1 or the mild grade of early classification, important the topical antibiotics or disinfection. For example, topical clindamycin washes can be given, or topical nadifloxacin or clindamycin can be applied. You can give a benzoyl peroxide wash for the patient to use, so that the role of biofilm is also not is also taken care of it. Sometimes if the patient has got any nodular cystic lesion and where you feel the intralesional steroids also has played an important role, zinc gluconate as an immunomodulator, and as I said in the last slide, tetracycline or doxycycline 50 to 100 milligram can be given for 12 weeks. When the patient goes to a stage 2 or stage 3, when we have got more than 5 to 6 nodular cystic lesions, then it is better to think of an antibiotic of clindamycin along with rifampicin, which can be used for 12 weeks. And still, if it is after the use of an antibiotic, if the disease still persists, meantime, you can just work up the patient for adalimumab, because TNF alpha inhibitors are the one which are found very effective in treating HS of stage 3 and stage 2. We cannot separate surgical treatment from the medical treatment, because during treatment of the patient, when you are doing an active disease, there are many times the flare-ups takes place, and just simple aspiration of the pus or doing IND or maybe a surgical laser. For example, if I see a stage 1 patient who has got a nodular lesion, there and there itself I recommend the patient you should simultaneously undergo hair removal laser, because that's one of the best way to take care of it. So this surgical or the laser hair removal is one of the best treatment which I advise in all the stages for the patient once they have the HS or any boil in the axillary or the groin area. It helps the patient to reduce the infection and the source of inflammation. The hair becomes thinner and the inflammatory process is reduced. And when we think there are multiple abscesses, then doing an incision and drainage, or for example, sometimes the people use carbon dioxide laser for evaporation of the diseased tissue, or draining of the fluctuant abscesses immediately release the pain. Local procedures like a sinus deroofing, or you can use the electrocautery to remove the sinus, or cryotherapy also can be done. And if it is a stage 3, the radical wide excision with the 2nd degree closure can be used along with the skin graft. But I have found the people who have already done so many times surgeries are having recurrences with the surgeries. So now it is better that we identify the disease patient earlier stages and start using with the long-term antibiotics along with adalimumab. So we don't allow the patient to have such a wide excision surgery. And patients are already suffered so much, they are not ready for the surgical excisions, especially if it's perianal area involvement is there. So a combination of laser along with our medical line of therapy will be the best option which we have, and we should utilize it for this knowledge for getting a better quality for the patients. Now, why should we think of using TNF inhibitors? Because it is seen that the TNF alpha, interleukin 1B and TN are highly increased in the patients who are having HS. And these pro-inflammatory cytokines, 11 lesions are highly increased in the lesions, as well as with the higher the number or the values of these TNF is correlate with the disease activity. So that means whenever there are flare-up or where the patient has got severe activity, there is a TNF alpha which is increased. So giving an anti-TNF immediately release the pain and the discomfort which patient has. There is the role of our biologics or biosimilar comes. Now, it is not that we have only biologics. We do have a lot of other immunomodulatory therapies reported in the treatment for HS. Like, for example, there are something like adalimumab, etanercept, infliximab. But amongst all, the adalimumab is the more appreciated drug, and it is more effective and safer also. Then rest of the other drugs, secukinumab, I had used in some patient, but it had not. The trial was done. It is not so effective as the adalimumab. And there are rituximab, CD20 inhibitors, ifalizumab. There are very few reports, but the effect with none of these drugs other than adalimumab are as effective as the other biologics. Maybe because of the strong tumor necrotic factor inhibitors, which has the membrane as well as transmembrane drug concentration. But how then still there are other drugs which can be used, like we can use methotrexate, cyclosporine, acitretin, dapsone, apremilast, and now JAK1 inhibitors. So as we know from this, there are multiple drugs options, but however, the treatment still remains difficult to treat the case because every case is challenging. Now, when we think of these immunosuppressants, then when to use methotrexate? Like, methotrexate was effective in HS when it was associated with other diseases such as Sappho syndrome, or a patient has coming joint pain or spondyloarthropathy, or HS with infliximab. These are the two, when the systemic involvement is much more, then these are the two drugs which are very effective. Then methotrexate can also be used as an option in the older patient with a lower body mass indices, but have no benefit to those receiving concurrent biologic therapy. So if you are giving adalimumab, we don't have to be scared about getting in the antibody formation and the reducing the effectiveness of the adalimumab. Acitretin is considered to be superior to isotretinoin in HS management, and is drug of choice when we have the disease in the form of an acne conglobata, where the severity of the disease is seen. Acitretin for 9 to 12 months were followed for the 4 years, and all these patients achieved remission and had significant reduction in the pain. Dapsone is recommended for the treatment of follicular occlusion in a moderate to severe cases. Even I have used dapsone in combination with the patients where we have to give the treatment for longer period because it has an anti-inflammatory effect as well as it is one of the drug which is easily available, and we have an experience with using the drug. And then oral corticosteroids are also variable, but during acute flare-ups it can be used. The oral corticosteroids are often used for the control of acute inflammatory flare-ups in combination with the other topical and or immunosuppressants, because just giving oral corticosteroids for a longer period and after the stoppings of the drugs, there can be the relapse and it can be severe form. Now, there are other medical treatments which are into the market, which will be coming into the pipeline, like bimekizumab, apremilast, or it could be hydroxychloroquine. So these are all drugs which are available, but we still need to have their reports, which will give us the idea whether it is useful. But I'm looking forward for the apremilast when used for a longer period as a drug can be used as a adjuvant along with the adalimumab or our existing therapy. These are the further another ways where we can treat the disease, like alexandrite lesion, botulinum toxin, sclerotherapy, microwave ablation, low dose radiotherapy, and intralesional transdermal. So the results are yet to be declared, but these are the drugs. These are specifically hair removal lasers are the options which we should start giving to the patient from the beginning, where we don't have to even wait for the results. Now, the newer molecule which we have received in last few days is the tofacitinib, which has shown benefit with the conjunction with the other therapies. So, as we all know, that tofacitinib acts to the JAK-STAT pathway by suppressing the inflammatory cytokines which are implicated in the HS, and which such as interleukin 1B, 1,6, and TNF-alpha. And the patients who are not responded to the biologic therapy, this can be an option which we can think of giving it, or we can try it using in the other patients also who, as one of the drugs, is new option which we have available. So the study, the literature says there are 2 reports about the patient who had a rare recalcitrant and ulcerating type of HS phenotype, who despite of not responding to the various treatments, including biologics, were given a tofacitinib along with the another immunosuppressant. It is not the drug which is given alone. Tofacitinib was given for 5 milligram 2 times a day, along with amoxicillin 500 milligram 2 times daily, with cyclosporin 300 milligram, that is 5 milligram per kg daily. And the second patient, second patient was given 4 weeks antibiotic along with amoxicillin clavulanic for 33 weeks, along with azithromycin, and mycophenolate mofetil was combined with the tofacitinib. Now, the tofacitinib with cyclosporin or mycophenolate mofetil was initiated with the antibiotics for the long management. So the treatment period was extremely long. And the cyclosporin and MAVIF served as a bridge therapy because of the tofacitinib has a very slow onset of action, and the patient had a very severe disease. So this is one option which we can combine two immunosuppressants, and if there is a recalcitrant case. So these are all other methods which we have, which we can give the medical and surgical treatment. But I always, again, I want to emphasize on the general measures are most important. Now here I would like to add to the thing that ask the patient to keep on massaging the area, to keep on draining the sinuses, or to give a pressure therapy so that the pus collection is also removed properly. The drainage of the sinuses also has to be taken care of it. Because doing some physiotherapy exercises will help the patient to remove the underlying the secretions which are there, or to help to get rid of the discharges which are coming. So cleaning the area is the most important part. Stop smoking and loose fitting clothes. Then this discharge can be very disturbing. So we should advise the patient something like an absorbent dressing, which are atraumatic and they can easily carry on their daily activities. Tegaderm dressing could be very useful when they can use it in axilla full day, and then they can carry on with their work. Now, topical therapies definitely has a role because clindamycin 0.1% can be used, 5% benzoyl peroxide washes can be used, and topical intralesional steroids if it is the very nodular lesion which is seen. Now, I would like to share some of my photographs where I treated the patients with doxycycline, with rifampicin and minocycline maintenance sometime, or with adalimumab. So this is a grade 1 stage where patient had got 3 lesions, and then gradually over a period of time, we can see in the stage 1, the patient has got difficulty in lifting the hand, and after the mobility of the joint is improved and the inflammation is improved. But this is still not a stage. When you see a patient and on the follow-up, when you ask the patient and examine and palpate the lesion, and if there's a still persistent pain, the patient has to continue taking the antibiotic for that period. So another drug which was used was metformin by me in some of the patients where it was given, treatment was continued for 24 weeks. And this is some of the results where swelling, the multiple sinuses are reduced, and the metformin shows improvement with the obesity part. Colchicine is also a combination therapy. For example, if I give doxy and rifampicin and afterwards I want to keep the patient on the minocycline, I add colchicine to the patient. So this combination therapy of capsule minocycline 100 milligram OD with colchicine 0.5 milligram 2 times a day for 6 months. And then you maintain the colchicine 0.5 milligram for further 3 months. So it's 9 months overall. The therapy can be assessed from the patient, can be assessed from baseline to every 3 months for the 9 months. And it is one of the safest options for the maintenance to obtain the result. Surgery, as we know, the incision and drainage, frank fluctuating abscesses are there. We can remove we can just do an IND where it is, but always the sinuses, the lesions, if the infection is not totally controlled from the cavity, there is always a recurrences rates. Other surgeries which can be done are electrocautery, wide surgical excision, CO2 laser, and the Nd:YAG laser. I prefer Nd:YAG laser for hair removal because it has got a deeper penetration and it works at the vascular as well as hair removal area. So the inflammation is reduced better. So this is the way one of my patients had got multiple painful lesions, used to get a severe exacerbation. So along with adalimumab, many times we have to combine it with the IND, and the lesions heal with scarring. And that scarring, then that area, the sinuses gets healed. Now, another important aspect which is emerged now is the considering the chronic pain in the patients of HS. So for that, we can give gabapentin, pregabalin, or we can use duloxetine which are the normal drugs which can be used to reduce the pain in a patient who has got HS. Now, this is my recent case whom I had treated. It's a 44-year-old married female, had distress by profession and came to the clinic with the multiple painful lesions in the groin for 7 to 8 years with a history of recurrences on and off, and patient had a weight gain over the past 5 years. There was no history of diabetes, hypertension, or dyslipidemia. This is after first adalimumab injection. Most of the swelling is reduced, and that's what the beauty of adalimumab is, that the drug acts faster to relieve the pain, and the quality of life of the patient is improved drastically. After second injection in the perianal, because perianal area is one more very difficult to treat area, and patient keeps on getting multiple sinuses, because if you are a sedentary job, the inflammation, edema tends to occur more in the perianal area. So after the injections, the sinuses are healed, but still the process is active. And now, after the 6 months of giving proper dosaging of adalimumab, most of the lesions are subsided. Patient just takes maybe 4 monthly or 6 monthly 1 or 2 adalimumab injections. And as and when sometime premenstrual there is an inflammation she notices, I keep her on doxycycline for 21 days. Is another young patient, female patient, had multiple inframammary and abdominal area. She used to get multiple discharging sinuses. And after adalimumab, most of the lesions of the nodules, they subside with a combination of an antibiotic. Perianal area, you can appreciate the multiple deep-seated interconnecting sinuses also can be seen in this case in the slide. And after adalimumab and in combination with the NDR laser, you can see the hyperpigmentation of the underlying sinuses and tracts. It's a condition where this was my first case of HS where I have given adalimumab along with the antibiotics in a perianal area. Perianal area is difficult to treat HS. This is the same patient on the another view where you can see the sinuses which are subsided with so much of an hyperpigmentation which actually correlates with the underlying sinus tracts which the patient had. So many times patient may have an associated severe scarring alopecia, multiple inflammatory nodules in the axillae, in the chest area. This could be an acne conglobata type of HS. After giving the adalimumab injection, the lesions are subsided. We can see the scarring is there, and now the physiotherapy patient is required to keep the exercises. And as and when the adalimumab injections are given to the patient to prevent the inflammation. But over a period of time, as we have seen, initially, if the requirement of adalimumab injection is there, the second year, third year, the requirement is reduced, and probably there could be a time where there could be a remission which would happen with any other disease. And IAVDL also has their own strength of recommendation for the therapies of HS based on the quality of evidence. The strength of recommendation is level A for adalimumab, as well as for the plastic surgery reconstruction, laser therapy, CO2 and NDR. Level B mainly for tetracycline, total excision of lesions, and infliximab. Level C is clindamycin oral with excision primary closure, and D is deroofing intense pulse light or corticosteroids. Colchicine, botulinum toxin are level 4 and with the cyclosporine. So these are the recommendations where, and now even the Brazilian, as we know, this HS is commonly seen in the African American population. And the Brazilian Dermatology Association has recommended now adalimumab as the first drug of choice to be given in the HS, because during my course of adalimumab in Henry Ford Hospital with Dr. Hamzavi, most of the patients had such an extensive type of sinuses, tract formations, and hardly any normal skin was seen. So for them, wide excision was there, but even in spite of that, their quality of life is affected so much that they cannot even walk. So it is better, it's challenging to treat the HS patient, but the awareness has to be there. We need to be explaining the patient, doing the counseling to the patient, that treatment is a prolonged treatment, and during that time we have to follow certain things, and we are the best people who can treat them, and from medical and surgical point of view. So I would like to summarize saying that successful management of hidradenitis suppurativa is challenging and at times requires comprehensive care. And there is no uniformly effective therapy for HS. And the management is subjective, and a choice of drug depends on the clinical severity, patient's profile, risk-benefit ratio, and the judgment of treating dermatologist. And different surgical interventions, laser therapy are effective when combined together. Thank you all for the patient listening.
Thank you, Dr. Sharmila Patil, for such an excellent talk on medical and surgical management and enlightening us about it with your before and after very good pictures. Thank you once again. Thank you, Sharmila. And I hand over the mic to Dr. Indra ma'am.
That was an excellent lecture and a comprehensive lecture on management of hidradenitis suppurativa, which is a very difficult condition. And we are very much motivated to use adalimumab, which is antofacitinib. After hearing your lecture, it's an excellent lecture. Thank you. And I hand over the mic to, I thank TSIADVL for giving us this opportunity. And now I hand over the mic to Dr. Jagannath sir for panel discussion.
So, on behalf of both the chairpersons, I also thank the organizers for giving us this opportunity to be the chairpersons for today's lecture.
It was actually an excellent talk by Dr. Patil.
Thank you.
Thank you. Very good talk.
Now we call upon Dr. Anand, who is a consultant dermatologist in KIMS Hospital, to start introduce the panelists and start the session. Panel discussion on hidradenitis suppurativa, where we are and where we are going. Over to Dr. Anand.
Good evening, madam. Yeah, my screen is visible.
Yes, yes. Very good.
Yeah.
Yes.
Okay. Yeah, Dr. Sharmila is a very nice talk. We learned a lot of things from you today's talk. And first of all, I would like to invite my panelists. The first one is Dr. Pathogenesis, senior most dermatologist is Anjala Skin Institute. Dr. Pathogenesis, sir. Good evening, sir.
Good evening. Good evening, Anand.
And second, Dr. Sharmila Patil. She's from DY Patil. She's a professor and HOD. She's a main speaker today. She has a vast experience in And third is Dr. Purna Chandra. She also spoke about the pathogenesis of HS, and she's a professor at ESI Medical College. And fourth is Dr. SB Kavita. She's a associate professor at Jagitala Medical College. So I would like to invite my panelists. So almost now I would like to go with the first question to Dr. Purna Chandra. Do you use any scoring system in your practice, routine scoring system? Like what scoring system? Because we have a different scoring systems like this. What scoring system do you use in routinely? Or do you use or do you won't use it?
I use Hurley staging.
Hurley staging.
Mostly, yeah. And basically we divide the area. So sometimes sartorius also, but mostly for severity of the lesions, that is grade 1, 2, 3, depending on that only we start the treatment. So I use mostly Hurley's.
Yeah, because there are a lot of scoring systems out there. That is hidradenitis suppurativa clinical response, and physician's global assessment, and modified sartorius score, and HS severity index, and body surface area, and international HS score system. Different systems, scoring systems are there, and mostly is like Hurley's and physician global assessment. Physician global assessment also they divide like mild, moderate, and severe. And if it is a mild is 1 to 4 inflammatory nodular lesions, and if it is or one abscess. If it is a moderate, more than 5 inflammatory lesions, one abscess or draining fistula. Is severe, 2 to 5 abscess and draining fistula or interconnecting senses. So if it is there, they call this a severe. This is a physician global assessment. The other one is routinely we use Hurley staging system. I think if anyone want to share extra about the scoring system, they can. Sir, Sharmila madam, do you want to share anything about the scoring system, or Partha sir, do you want to share anything about scoring system?
It is called as mild, moderate, and severe. Stage 1, stage 2, and stage 3.
Stage 3.
The early stage 1 and stage 2, stage 3. If you have only a few, 1 or 2 nodules or papules or pustules, a few lesions, 1 or few, then we call it a stage. If there are sinus tracts as well as the abscesses or maybe scar formation, that is called as stage 2. Suppose the areas are involved, multiple areas are involved. It's only regional stage 2. Stage 3 is beyond the region. It involves the axilla, groins, the abdomen, chest, and then pubic area and all those things, perineal areas. Then we go to stage 3. So that is what we see. So these are the stages which everybody knows. Depending on that only, we try to give the treatment.
Okay. Yeah, and next question, Dr. S.P. Kavita. What topical medications do you prefer?
Most of the, in case of topical medications you're asking, means in the grade 1, usually where they have single or 2 or 3 nodules, I usually go with topical clindamycin, my preference of choices. Sometimes I go with intralesional steroid also, around 3 to 5 mg. This is what I usually prescribe. So from ma'am stock, so Brivoxil washes are working out, that I have to try now. So topical, usually go with clindamycin alone. Sometimes metrogel also, metronidazole gels.
There is a lot of talk about resarcinol, 15% resarcinol, but I didn't get it resarcinol, and I don't think it is available. Maybe you have to compound it. That is what I feel. But many of the Westerners have tried resarcinol cream as such, and it has been found to be very useful. There are some clinical trials also which they have done, except the post-inflammatory hyperpigmentation. The resarcinol 15% is a good option, it seems, but we don't have it in India.
Even ozenoxacin could be tried now because it's a new molecule which we have. We can use it.
Okay.
We'll see.
Yeah.
And another thing is I always go for betadine powder if something oozing and all those things is there. That topically that will be very soothing for the patients actually. So that is another thing which I always insist upon, apart from the antibacterial creams like clindamycin. And mild soap was actually soap-free soap was will be better. That is another thing. Maybe some warm compresses to soothe the skin and soothe the inflammation, that also will be useful. This is what we do topically.
Yeah. Resorcinol is fusidic acid, benzyl peroxide washes, chlorhexidine washes. Yeah. This is already Shibna madam covered, like tetracyclines or doxycycline, like for grade 1 acne for 12 weeks, and second line agent for the mild disease like rifampicin and clindamycin. So, Shibna madam, how much effective of rifampicin and clindamycin combination? Is it?
Actually, I don't use clindamycin. I use rifampicin and levofloxacin combination. Somehow, I don't know. I don't use clindamycin systemically, and I found it is definitely useful whenever like patient requires that inflammatory nodular parts regions are there, and I give it for 3 weeks, and rifampicin I continue for 12 weeks, and then I followed with the doxy. So in most of the cases, it has been effective in the patients to take care of it.
Okay.
And that they get a prolonged remission if it is in a stage 2 or stage 1.
Okay. Sir, Partha has any experience?
Actually, antibiotics are a must because secondary infection may set in most of the cases. There are so many options from doxy to minocycline to rifampicin to clindamycin to levofloxacin to amoxicillin plus clavulanic acid. There are so many antibiotic options. So you have to choose depending upon your, maybe you can do a swab for calcium also. But what I do is for males, I never go with only antibiotics. I always put them on either acetretin or isotretinoin. Isotretinoin in higher doses, not in 20 milligram, 30 milligram, always should be 40 and above. And acetretin also used to be 50 milligram. I mean, for adult I'm talking about. In case of females, I don't use them unless the patient is has passed her name. She got these 2 children, and then she's not going for any pregnancies and all those things. But most of the times, most of the people forget about cotrimoxazole, which is a very good drug. We are afraid of the cotrimoxazole reaction. That's why we are not using them, because we have seen quite a good number of Steven Johnson syndrome cases with cotrimoxazole. But I have 2 cases where the isotretinoin plus cotrimoxazole combinations for 6 months have given wonderful results. So that is also a good option, cotrimoxazole. Instead of dapsone, I always go for cotrimoxazole, which is a little bit better drug than dapsone. That is what I feel. So these are the antibiotics which are available. And depending upon your choice, it all depends upon the doctor's choice, which one he wants to choose.
Sharmila madam, for the rifampicin 600 mg daily, so you'll be advising for 12 weeks, madam? Daily?
Yes, I advise them to take daily. In fact, they are scared, like, madam, why you want to start on rifampicin? But I do advise for a long term.
Any side
here
effects?
I have not seen side effects, and I'm not scared that whether the tuberculosis people, because it's difficult to consider giving only rifampicin in a patient in India where tuberculosis is very
more.
Thank you.
So, yeah. What are the second line antibiotic for moderate to severe HS? Anybody has experience with metronidazole or moxifloxacillin rifampicin combination? It is reported in the literature where it is not responding to the rifampicin routine antibiotic. They started metronidazole, moxifloxacillin, and rifampicin. Sharmila madam already told that she used rifampicin and levofloxacillin, right? And in some series, they have given about 3 antibiotics like metronidazole, moxifloxacin, and rifampicin. Anyone has experience with 3 antibiotics?
I didn't try any metronidazole so far, Dr. Anand. I didn't try metronidazole combination.
Yeah. Okay. So,
actually, I tried only with the 2 antibiotics, like going with the metronidazole and augmentin, actually amoxicillin clavulanate. These are my drug of choice mostly.
Yeah.
3 antibiotics I've never tried.
Okay.
Sometimes steroids.
Even some of the literature, for like foreign literature, this mention of giving IV higher antibiotics like meropenem, and there are a lot of reports where they consider giving IV antibiotics, but I think in India we don't. Yeah, correct.
Yeah. This is the one like carbapenem, so like ertapenem. It is available in India, madam. It is IV antibiotic. It is available. This is available. Ertapenem is available.
Yes, but we don't prefer to give because we have other options and we treat them.
Like sometimes, if you according to the culture sensitivity, then we have to take infectious disease specialist opinion. Then if it is severe inflammatory is there, infection spot is there, then we can give ertapenem or imipenem, ferropenem. Yes, we can give. This is then reported in the intravenous ertapenem is reserved for severe treatment refractory HS.
Yeah.
It is available in India. And I think you mentioned about the dapsone, right, madam?
Yes.
Yeah, you mentioned about the dapsone, and sir mentioned about Bactrim DS also. It's like sulfadex. Yes, it can be used in HS. And apart from the antibiotic role, what are the other roles of antibiotics in HS? Is there any anti-immunomodulatory effect? Or is it only antibiotic role in the antibiotics?
Anti-inflammatory effect is there more when we use for longer period.
Like
Doxy and Mino are immunomodulatory also. Anti-inflammatory, immunomodulatory as well as antibiotic.
Yeah, yes. Even rifampicin also by altering NF-kB activator protein, nitric oxide synthase, doxy and moxifloxacillin also has some immunomodulatory effect. Even also metronidazole, carbapenem also has some immunomodulatory effect. So apart from antibiotic effect, these antibiotics also has a immunomodulatory effects. And these are some questions so that we can have some case-to-case discussion. She is a 33 years female patient. She completed her family and she has a HS almost like 6 to 7 years. She has a PCOD and also acne, insulin resistant, and she has a female pattern baldness, and she recently developed arthritis, severe joint pains also. And she was treated previously with oral contraceptive pills, metformin and isotretinoin previously. So when she presented to me, this was a case. So there is a sinus tract, interconnecting sinus tracts and pus discharging on both the axilla. So it's very painful. She has a severe joint pains also. So what we did, I refer to the plastic surgeon. They did de-roofing surgery. Then this took the pus culture. According to the pus culture sensitivity, cefofrogen salbactam is a Magnexport for 1.5 grams BD. That is for Proteus mirabilis was given for 14 days. After 14 days, after surgery and antibiotic, this was the situation. And then I added rifampicin and clindamycin. and along with adalimumab also. I given 160 mg and at day 15 80 mg, and at the 2 weeks of first shot only this was a response. She has a very good response, and our joint pains also is subsided. I added low dose of systemic steroid also, and rheumatologist also added sulfasalazine for her because she thought of Sapho syndrome. So my question is, in this patient, retinoids didn't work for her. So a role of isotretinoin in HS, because most of them we prescribe isotretinoin, most of the prescription I say isotretinoin. How much of a role is there isotretinoin or acetretinoin compared to acetretinoin isotretinoin?
Acetretinoin is better than isotretinoin. There is no doubt about that. This is mainly for the normal re-epithelialization of the follicular unit. That is the main this thing. And acetretinoin has also anti-inflammatory properties. Acetretinoin is a better drug when compared to isotretinoin. But isotretinoin, even though people say the Westerners, they say foo-foo the idea. But practically we have seen patients, responding dramatically to isotretinoin also. Some of the patients. Like suppose if adalimumab is there, adalimumab, what is the percentage of patients are recovering? Around 60%, 50 to 60%. So is the case with acetretinoin also and acetretinoin also. But definitely acetretinoin is a better drug than isotretinoin. But we can't give them to childbearing potential women.
Yeah.
So that is the only problem.
Madam, in this patient also, Sharmila madam, even they treated with OC pills also. Yeah, as Partha I rightly mentioned, like isotretinoin is not recommended for routine treatment. Acetretinoin may be used as second or third line therapy. These are some literature. How much is effective is isotretinoin? In some cases, with isotretinoin, there is a one series where it is aggravated of HS, exacerbation of HS due to isotretinoin. And yes, definitely the high dose of acetretinoin is more effective than the low dose of lower doses like 0.5 to 0.6 mg per kg body weight. And Sharmila madam, in this patient, initially they treated like hormonal therapies, and even hormonal therapies are also is not that effective.
Yes. In fact,
So,
I feel that the target is TNF factors. We should treat TNF factor and the bacterial as well as even acetretinoin now can be a good option. That's the better because hormones, how long are we going to control? And I not given any patient oral contraceptives who has HS.
okay. Kavita and Purnachandra, any experience?
I have not given any OCPs, sir. So,
Other than metformin, I've never tried other drugs unless obese.
Okay. Okay. Yeah. And finasteride is another hormonal therapy. In some cases, they recommended who's completed family. They showed that there is a significant improvement was observed in 13 out of 14 participants across 4 case series. Any experience with finasteride? I also never tried for HS.
And I think when we understand the pathogenesis of HS is mainly
there is no interest.
Yeah, it's mainly the inflammation. So hormones has little bit less role to play with it.
Yeah.
And androgens are normal actually.
Yeah.
And anti-androgen therapy, it is mainly directed for female patients, not for males.
No, those who are having PCOD, polycystic ovary syndrome with hirsutism, I think definitely they do work to a certain extent. They are not the mainstay of treatment, but they do help. Like metformin helps, like finasteride or oral contraceptive combinations, especially cyproterine and ethanyl estradiol, and finasteride in higher doses do help to a certain extent. But usually we don't try them. Most of the times we don't try them.
Madam, this is a photo after giving a adalimumab 180 mg. After 2 weeks of this is the response, excellent response. And I given even 80 mg also after 15 days. And after another 2 weeks, again, she is developing these lesions. You can see the lesion here in the left axilla. So I thought right now she's on adalimumab and sulfasalazine, rifampicin and clindamycin I stopped. I given for 2 months and I stopped. And she's recurring these lesions. So then how to manage? Do you want to recommend for another antibiotic continuously for along with the adalimumab, or you want to add something else like other immunosuppressive medications, not only for adalimumab, like methotrexate like that?
Shall I say?
Yes, sir. Yes.
I'd prefer first is important for her to keep on Like the local care. Secondly, she has to continue doing some exercises of that area so that there's no drainage on the pockets of foam. And topical benzoyl wash, or even if in case to be continued, topical antibiotic, and then systemic minocycline and colchicine can be a good combination. We can continue. Meantime, she would get some exacerbation possibility, and if as and when required, you can even give adalimumab, because the quality of life what they get with adalimumab is much better. So adalimumab with minocycline as a continuation with colchicine could be better for next 9 months to manage with the local care.
Local care. Can we add methotrexate also because she has a joint pains and suspected case of SAPO syndrome?
So actually, adalimumab works very well for the joint pain also. For example, even psoriatic also are given adalimumab with the joint pain. So it works. So why to give one more drug? We can keep it for the spare if in case if required. Because giving adalimumab once in 3 months or once in month will really take care of the inflammation.
Yeah.
And long-term antibiotic you can continue giving as an immunomodulator, as an anti-inflammatory. Methotrexate can be
Yes.
considered. Why not?
In cases which are not responding, there is not a bad idea of adding methotrexate, because TNF alpha inhibitors and methotrexate, they go well actually. Infliximab methotrexate has given very good results. Etanercept with methotrexate has given good results, but adalimumab and methotrexate also has been tried actually in 3 cases. So there is not, it's not a bad idea to add methotrexate if at all patient is not responding. But the thing is that adalimumab has to be continued. We just continue it for 3 months and stop it, but it has to be continued for 6 months to 1 year. That will be the better. You have to continue adalimumab, and maybe as madam has said, you can add the rifampicin or the minocycline plus colchicine, or maybe the methotrexate also we can add, depending upon the patient's response.
Yeah. Okay. Comes to the next second case, sir. This is a second case. He's a 26 years male. He is working in Australia. There he got HS and severe HS. He was treated in Australia only by dermatologist, and he was treated with clindamycin, rifampicin, and systemic steroid also. Initially treated with systemic steroid and also metronidazole. So HS was almost all subsided. It's almost subsided. Right now, you can see there's a scarring is there, contraction is there, and moist area is there on both axilla. But this is a letter they mentioned when he was coming to India for the biologicals, because he doesn't have insurance for biologicals there, so he came to here. So they recommended like either IVIG or adalimumab or tilrekimab. So here, is there any role of IVIG in HS? Any experience? But they suspected along with pyoderma gangrenosum also, HS with pyoderma gangrenosum, but it looked like HS only.
No experience with IVIG.
Yeah, even I searched the literature also doesn't seem to be any cases.
Rituximab has been tried, but IVIG we are not sure. Maybe
sure,
it has been tried, but rituximab has been tried.
Yeah. So after starting off adalimumab and first shot all the lesions, then I called Dr. Sharmila Patil regarding this case only because it was very moist. I was scared to give adalimumab because is there any infectious focus is there? Then I took her opinion and she said you can give. So then I administered adalimumab 180 mg, and first shot only all the lesions became dry, completely dry in 2 weeks of time. So but contraction is there. And now the question is corticosteroid. With this case only, I came to know first time that yes, corticosteroid can also be used in HS. So when to use corticosteroid? Like yes, intralesional is there. Systemic corticosteroid. When to use? In what conditions? And how much dose? How long? A role of systemic corticosteroids in HS.
And then all the 3 stages have acute and chronic this thing. There will be acute flares up in the stage 1, stage 2, or stage 3. There will be acute flare ups. So whenever there is an acute flare up,
Sir, your voice is not. Hello.
You can give a high dose of steroid within a short 7 days. You can taper it off. That is the best way of giving a steroid in hydradenitis suppurativa, especially in acute flares, not for months together.
Okay, Sharmila madam, any experience?
I've just given intralesional, but when I had a word with Dr. Hamzavi, what they say that they don't prefer systemic steroids for HS because it's a chronic disease, and for example, if there could be some bone osteomyelitis or chances are there, so they don't prefer to give steroids. But acute flares, yes, it is mentioned.
Yeah. Okay. Then I stopped systemic corticosteroid and slowly I introduced adalimumab. Now he's doing fine. Okay, this is another case, madam. This a patient was taken adalimumab. This was not my patient. He was already treated with adalimumab. The dose was given is 80 mg is a loading dose, 40 mg in a week one, like psoriasis, and then 40 mg once in 2 weeks. But there was a no complete response. So you can see is a perianal area and both axilla looks fine, but his perianal area is not completely respond. So is there any difference between giving the psoriasis dose or HS dose? The psoriasis dose we usually will give 80 mg in day one, and in a 1 week 40 mg, and every other week is 40 mg. But in HS almost is a double the dose, like 160 mg initially for loading, then one in a week of time 80 mg, and followed by sometimes every other week or sometimes weekly once for 40 mg. Is there any difference between the two doses?
Now I prefer to give, if the patient can afford, I prefer to give a higher dosage because the results are better and the remission remains longer period. And compared to, and another is perianal area, treating HS is really very difficult and challenging. And in perianal area is a condition where, we can think of giving IV metrogel or IV drugs so that infection part in the deep sinuses is taken care of.
Yeah.
Yeah, for Hidradenitis suppurativa, the dose should be higher, Dr. Anand. Always should be higher, 160 milligram followed by 80 milligram after 1 week, followed by once in a week or once in 2 weeks, either 40 milligram or 80 milligram. So we cannot give a psoriatic dose. There's a lot of difference between these two. So this is the double the dose of psoriasis almost.
Yeah. Yeah. This. So how long we have to give adalimumab?
Ideally lifelong till the patient has undergone a remission. And
in your patients, how long they are on adalimumab?
most of my patients are now more than 5 to 6 years on the therapy, but they take the adalimumab when they are in a very acute flare up and the stages, and then in between I keep them on colchicine, doxycycline, and now sometimes even few of them are on methotrexate also, and now acitretin, since it is their option. So the severity of a disease comes down and their lives become manageable with the therapy what they have, but that acute pain and agony which they had when they are presenting to us is actually in a remission.
Okay. If there is a like grade 3 heart disease is there is a sinus abscesses are there. So when do you recommend the surgery? So the patient is on adalimumab therapy, do you recommend surgery? Do you want to stop the adalimumab and recommend the surgery, or you want to restart, or during on the adalimumab only we have to take for the surgery?
I give the option to the patient, but most of my patients are not ready to go for a surgery. And I do get the patients who are already had many surgeries done. In fact, last week only I had an experience with a patient who had come all the way from Hong Kong. In Hong Kong, they don't refer HS patient to dermatologist. The patient has to go to plastic surgeon, and plastic surgeon never takes a dermatologist opinion, and they keep on doing perianal surgeries. And he had got surgeries done 3 times a day, 3 times in last 4 years, and had a really bad course. So I don't recommend now a patient surgery. I prefer to convince the patient to take adalimumab and with our antibiotics and under our care. And at the same time, I do take their opinion, but patients are not ready for surgeries. And I really feel adalimumab we are the one who can stop the requirements of surgeries, because the amount of pain they go through surgery and the contractures and the difficulties they face are tremendous compared to the cost of adalimumab and our supervision and a proper meticulous monitoring of the patient.
And regarding the infectious part, suppose infection is there, pus is there, if it is a culture sensitivity, some bacteria grown, do you treat for the antibiotics first and then you
Yes,
start?
sir. Before giving adalimumab, we have to treat infection, because we cannot treat without having a sterile pus swab.
Yeah.
Anemia and no pus, that's a criteria.
Okay. Sir, this is another case where 58-year-old male patient with HS, diabetic, 10 years back suffered with multi-drug resistant pulmonary tuberculosis. He was treated in Chennai with difficulty. He was managed for tuberculosis. So now he has a HS according to the culture sensitivity with proper local care. Cefodoxime proxetil and potassium clavulate BD was given and deroofing surgery was done. So this is a patient. So how to manage this case next? He has a multi-drug resistant tuberculosis. He's
Any
almost
fluoroquinolones?
grade 3 disease.
Any fluoroquinolones been tried?
No, he's on systemic antibiotic only, like anti-inflammatory agent. Apart from the antibiotics, what anti-inflammatory like adalimumab or something else? Can you give adalimumab in this patient? Is already MDR multi-drug resistant tuberculosis.
No. Continue anti-tuberculosis treatment and go for secukinumab. Secukinumab is not a bad idea.
Secukinumab is not a bad idea.
You can continue ATT. Along with that, you can give secukinumab. If at all you want to give a biological, secukinumab is the best one in case of tuberculosis.
If not the biological survey, what are the other drugs we can give in this patient? If not the biologicals, yeah, secukinumab is option. Adalimumab is not at all option. Yeah, if not the secukinumab, you want to manage with other oral medications.
As sir pointed out, Septron can be tried, I think, in this case.
Bactrim DS. No, apart from the antibiotic, what are the other immunosuppressive medications? Immunomodulatory medications.
Okay.
So first 2 months of intensive therapy with the ATT, you can give methotrexate also.
Yeah, methotrexate.
Apremilast would have been, maybe you can try apremilast, but we are not sure whether really apremilast is going to work, but we can try apremilast.
Yeah. I started for this patient both apremilast and isotretinoin also. I'm waiting for the response. I started both apremilast and isotretinoin, so I'm waiting for the response. And the other options like colchicine and cyclosporin to control the activity of the disease. Cyclosporin also like along with rifampicin, multi-drug resistant. Okay. This is another patient. Sir, is a 15 years old girl, obese, irregular periods, acanthosis nigricans, and she has HS also. These are HS. Seems to be a grade 2. How to manage, madam, this case? Any role of lasers in this patient?
As I say, laser is there required for every stage. That 100% laser has to be done because it does help the patient to reduce the recurrences of the lesions. But even isotretinoin also, because most of the lesions look like a follicular. So even she has got acanthosis nigricans. So metformin along with isotretinoin I can try in this girl.
In this girl, okay. Even long pulse Nd:YAG laser, even grade 1, grade 2, it doesn't work.
Yes, sir. Nd:YAG laser is really very useful in treating HS. In fact, the patients are from different places. They don't follow up. But if you convince the patient has to take laser, it works extremely good to, it's an adjuvant therapy to take care of requirements of the other medical
Yes, I saw some papers are there where long pulse Nd:YAG they have given for not only for laser removal, for HS also they have tried.
Yeah, Dr. Anand, actually in early stages, to remove the hair, you can go for hair removal laser, any one of that. But later on, CO2 lasers and Nd:YAG lasers do help, especially CO2 lasers is more useful. If at all you want to destroy that particular inflammatory process, and even the sinus tracts also can be tackled with CO2 laser. Only thing is we're afraid to give CO2 laser, but otherwise CO2 laser is a good option. When they are doing cryo suction, cryo infusions, I don't think the CO2 laser will not work. It will definitely work, CO2 laser.
In fact, many abscesses or sinuses just open with the CO2 laser and let it heal by secondary intention. The scarring takes place, and that's the way how it works.
So HS in pediatrics, like 15. So comorbidities like acne, hirsutism, pylonodal cysts. Generally, obesity was a prominent in pediatric patients, was related to the parent BMI. Lastly, the way in which disease was managed in pediatric patients was similar to that in the patients, but younger patients are more exhibited milder disease. So the management of HS in pediatrics and adults is no difference, is almost all same. Madam, in pediatrics, adalimumab, from what age you will recommend?
It's about 12, they say. about 12 years of age, you can give adalimumab.
Yeah.
Yeah, about 12 years age. What is the dose, madam, in the pediatrics?
That is similar to psoriasis, because we see the weight which is higher, we give 160, or if it is lesser weight, then you have to give 80.
Yeah, in adolescent, initially 80 mg, yes, after a week, then
Yes.
40 mg. After that, every 2 weeks in 40 mg, like similar to psoriasis.
Yeah.
Yeah.
Another important part in pubertal HS, like actually I have not seen any HS in pediatric age group, but they say you have to look for precocious puberty. So maybe we can take a pediatrician's opinion to look for it, because they are very common to get an early precocious puberty if they have an HS in the pediatric age group.
Madam, now the pediatric age group has gone to 20 also, I think. Previously it was 12, then later on 14, then 16. Now they have gone up to 18, maybe they may go to 20 also.
These are the lasers we discussed already regarding NDI. This is a case, I took it from the journals to make it more interesting. She 24-year-old non-smoking patient who had HS for 6 years, presented with recurrent inflammatory nodules, extensive cutaneous inflammation, mainly affecting the groins and gluteal region. Previous therapies include combination of clindamycin, rifampicin, isotretinoin or isotretinoin 30 mg per day. Anti-TNF alpha treatment with adalimumab, infliximab had no effect on the severity course of the HS lesion. Void excision and of the abscess sinus tracts in the both groins gluteal region with subsequent secondary healing was performed 1 year before the presentation. At presentation, the patient had a recurrent HS with many highly inflammatory nodules extensively affected groins and gluteal area. And how to manage? Already she had a surgery and again it is recurred. Previously, she no response with adalimumab, infliximab, rifampicin, clindamycin, no response at all.
Best way is to re-investigate her by doing MRI and try to see where are the sinuses yet there. And that will help us to understand, and if it is some sinus tracts are still continuing, would be here the role of plastic surgeon would come to take care of those sinuses if they're existing.
Okay.
MRI of the patient will help us to understand the underlying pathology and how severe it is and which places still the sinus tract is open.
Anand, you can try another biological, maybe that may be useful, secukinumab or maybe istokinumab if at all is available, that IL-12, IL-23 inhibitor, that also will be a good option.
This patient was treated with secukinumab and she responded. This is not my case, this is a reported. Just to make it is interesting panel discussion, I took it. Yes. And this another case, this is also is a case report. How to close this? She has extensive HS, is like almost all, she was treated, excision surgery, she was treated with all the medications, and at last she has like this. She's a female patient, extensive scarring, extensive fibrotic scarring over both is around the perianal gluteal area, and even you can see groin area, and you can see labia. Yeah, so labia is extensively swollen like this. So they manage it surgically. So it is like is end stage HS, like is totally completely fibrotic tissue. I had one patient from US. She was a pharmacy student, and she's a very thin lady. She don't have any abnormalities. Very thin. She's a pharmacy student. She's doing job in US. She has a dream to go to US, and she has a HS. In spite of that, she know it, but she didn't take care of. She didn't take care of it, and extensive sinuses tracts, and it is healed completely with extensive scarring. Both axilla scarred and both groin perianal area, labia is completely scarred, and completely when vaginal stenosis occurred. And she said she don't want to marry also. So in such cases, it's like it's completely scarred disease. To improve their quality of life, what can be done?
I think the same wide surgical excision followed by grafting, that is the best way to treat them, followed by the oral medications.
Yeah, she was treated like that. This patient is also treated like completely excision of the scar tissue and followed by the grafting, split thickness grafting.
Probably if they would have given adalimumab earlier.
This is in 2010. Probably if you have, Yeah, that is my question, madam. If you have given adalimumab, because this was reported in 2010, suppose if a senior is present right now, if you have given adalimumab, is there any difference?
I personally feel yes, it is, because plastic
Yeah.
surgeons are not
Hello.
aware of adalimumab. Plus, we are also seeing that patients with vitiligo also how they treat differently because they don't understand the pathology. So adalimumab would have made a difference if it would have been tried. But I don't know whether this patient had treated or not. Or
Yeah, yes, definitely. Adalimumab definitely would have made a difference for her.
Yeah. This is another case. She's a 36-year-old African. This is also taken from the journal to make it more interesting. She's a pregnant lady. She's in Gravida 1. She's a known case of, she's right now 26 weeks of gestation. She had a 30 years history of HS involving bilateral breast, axilla grinds. She was treated by dermatologists with steroid injections, adalimumab for 6 months prior to her presentation. She was morbidly obese, BMI is 47.5, non-smoker, physical examination, acute chronically inflamed draining nodules involving the areola and breast of 3 o'clock and 8 o'clock position, left breast and both axilla had healed scars with previously HS. So following conception of her pregnancy, she discontinued adalimumab with subsequent worsening of her HS, because in pregnancy, HS can aggravate. Over the course of 2 months, she was presented several times to emergency department, twice with cellulitis of the right breast, for which she was prescribed oral antibiotics and discharged home. At her third presentation, she had a fever, tachycardia, leukocytosis, right breast cellulitis, actively draining senses. At this presentation, she was admitted for IV antibiotic and surgical consultation was taken, bedside ultrasound because she is pregnant, MRI was not done, bedside ultrasound revealed which was not amenable to final aspiration due to the thickness of the purulent fluid, and she was taken to the operation room and underwent incision and drainage of the right breast and placement of a Jackson Pratt drain. Her wound cultures grew Streptococcus constellatus, Pseudomonas aeruginosa, methicillin susceptible Staphylococcus aureus. She was discharged home with 6 weeks of IV meropenem and piperacillin tazobactam. Her drain was inadvertently discharged 2 weeks after the placement, and right breast ultrasound did not show any fluid collections. So this was a case presented during the 28 weeks of the pregnancy. You can see this drainage for the pus collection. So she was seen 4 weeks after the completion of IV antibiotics, and she was noted to have a central mass of right breast with multiple scars and erythematous draining nodules. At this time, she was admitted to the obstetric services with consultation provided by the breast surgeon and infectious disease. She underwent ultrasound of the right breast, which showed loculated interconnected abscess. So given her unrelating condition, she was taken to the operating room for wide local excision of the affected area with continuous fetal monitoring. So this is during the pregnancy, 28 week of pregnancy, she was operated with wide local excision. So she was treated with piperacillin, tazobactam, and meropenem. Subsequently developed bilateral lower extremity erythema nodosum. So her treatment was then changed to vancomycin, ceftazidime, metronidazole. She was managed with wet to dry dressings for 2 days post-operatively and negative pressure wound therapy for 5 days. She was taken back to the operating room for delayed primary closure of the wound with nylon vertical mattress suture. She was seen 14 days post-operatively for suture removal, and her wound was healthy without any signs of infection. After delivery also, she was able to successfully breastfeed her baby, and after a year up, she has no recurrence in the breast. So this is here. So in such cases of HS in pregnancy, this is the only one case report I found. Even I think in Neena Madnani madam also asked about regarding this HS in pregnancy. How to manage HS in pregnancy? Because there is a known case of HS already there. If they become pregnant and there is a chances of aggravation of the HS in the pregnancy, almost all the immunosuppressive medicines, even adalimumab also cannot be given in the pregnancy. And how to prevent or how to avoid aggravation? What medications we can prefer? Hello? Hello?
Yeah. Audible.
Wait till the pregnancy is over. That is one of the options. Because most of the times pregnancy, usually the disease comes down. Surprisingly, the disease comes down, but some of the cases are there where in pregnancy the disease gets abated. I mean, increased also. But I think we have to go for supportive therapies only. That is what I feel. If infection is there, maybe repeated antibiotics can be given. Apremilast also cannot be tried in pregnancy. Even though it is category C drug, we cannot try it.
Abdominal pregnancy can be given.
Yeah, even though it is
Dapsone,
category C, but many of the patients, I mean, they're not foolproof reports regarding apremilast in pregnancy. That's why.
Dapsone, sir, Dapsone is option.
Dapsone can be given, but with a pinch of salt, because we should be a little bit careful about hemolysis and all those things. But again, of course, we can do G6PD to see whether hemolysis occurs or not.
Yeah. Hello.
About cryoinsufflation.
Similar-
Maybe some laser procedures can be done. Maybe, I mean, not these type of severe cases, and maybe mild to moderate cases. Maybe we can try a laser, CO2 laser, and then go for some antibiotics.
Yeah. Anyone add anything else?
Sir, cryo, how about cryo? Hello?
Yeah.
Hello.
How
Cryo
about
also can be
cryo?
given. Cryo also can be given. Yes, it can be given. Cryotherapy also can be given.
No.
Maybe acute flare up in pregnancy, can we use a short course of steroid? I don't know. I just maybe.
We can do.
Yeah.
Yes.
It's safest than the other drugs.
Yes, we can.
Yeah, that's what.
Second trimester cyclosporin also option. Yes.
Yeah, cyclosporin.
In pregnancy, the European literature says that the disease is better, and in the American literature says the disease that are worsening takes place. So we still need to do a lot of studies.
Which one, madam?
in HS.
Maybe cyclosporin is also another option. Dr. Kavita is pointing out.
Which-
Cyclosporin also could be another option.
Yeah, Sharmila madam, this is another question for you. In surgical, there's the two techniques like deroofing versus excision. Which one you prefers, deroofing or excision?
Ideally, deroofing is immediate
Hello?
relief, patient
I'm
get
not
it,
able to hear.
but if I had to do a surgical intervention, I keep it up to surgeons reviewed what they want to do it, because deroofing will immediately remove the pain, and then after the antibiotics I add adalimumab, so it could be fine. But wide excisions,
Yeah.
I don't.
Maybe it depends on the extent of involvement.
Exactly.
If it is very mild, deroofing can give relief, lot of relief. Excision depends on the surgical hands.
The first photograph is the excision, is completely excision of the sinus tract, and second photograph you can see the scissors. Then only the roof is called deroofing. So that is the difference. There's a difference, but in the sinus tract is persist. So this is a one article where they compared the deroofing versus the local excision, and complication rate and recurrence rate in local excision is more than the deroofing. The recurrence rate is almost double. Recurrence rate is double in local excision, and in deroofing is 15%. And even compared to patients wise and lesions wise also, the lesions wise also is excision is more if you do the excision of the local excision, and complication rate is also more, because in the local excision you have more pain and more bleeding and more scar formation and more time to heal also. So
yeah, and deroofing along with curettage till the gelatinous material comes out until it is a pale granulation tissue. That is the best way. Deroofing as well as the curating also will be very good, especially for a few lesions, not for extensive lesions.
Yeah, if it combined with medical therapy and surgical therapy simultaneously, and they reported that, and recurrent rate definitely, if you combine with medical therapy along with surgery, recurrence rate definitely drastically decreases 50%, but the complication rate also increases, because these immunomodulatory medications will delay the wound healing. That can lead to the secondary infection, pain, contract. So that is another problem if you combine medical therapy with surgical therapy. And so botulinum toxin, few reports are there where 4 cases were treated with botulinum toxins. Anybody has experience in botulinum toxin with HS?
No.
Yeah, we can skip this question.
I don't have any experience, but reports are there. I don't have any personal experience.
Yeah. This is a just literature point of view. Is a the few studies are there where they are doing predictive markers, because in some patients they are responding to adalimumab, some patients they are respond to secukinumab, and some patients they won't respond to biologicals. So is there any predictive biomarkers before giving some therapy, so that before giving adalimumab, if you do some predictive markers like interleukin-6 or some biomarkers, so if these biomarkers are elevated, and those patients will respond to this kind of biological, like that, is there? Yeah, then I searched in a one study,
Yeah.
this was reported in JARD. In this pilot study, to determine before giving infliximab, they did C-reactive protein and interleukin-6.
Yeah, that's really good. If you get the CRP and IL-6, then that's really good.
Looking is elevated and it will respond to infliximab. But fractal can, these are the but so like these are the biomarkers, they are doing it before giving the therapy, which medicine is working or not working. Yeah. Is there any role of diet and HS? Kavita,
glycemic. Those who have high glycemic index, they should be avoided. Dairy products and those with high glycemic
Low
index,
carbohydrates.
low carbohydrate diets should be avoided, and reduce obesity. That is more important.
Yeah.
yeah. And these are the few ongoing trials in HS, like different risankizumab and bimekizumab. Avacopan is a C5a receptor, tofacitinib, vidicitinib, all these things is undergoing trials. Okay, this is already controlled. So probably in the future, treatment should be like personalized therapy with biomarkers and pharmacogenetics, pharmacogenomics, probably to make it precisely treat to reduce the complications of the medication, because it's a lifelong disease. It is highly morbid. To improve the quality of life, probably in the future, we may get like personalized therapy with pharmacogenetics, with biomarker assessment. Okay, thank you so much.
Dr. Patil, madam, one question to you. Did you try any tofacitinib in your patients? Did you try tofacitinib in any one of your patients?
No, I have not tried. Actually,
Tried.
Maybe I'm very much now for adalimumab and seeing results.
Okay.
So, but it's a good molecule which you can try.
Any questions from the audience, Anu? You have received any questions from audience?
Yes, madam. I think in the chat box, I will let me to go.
Ma'am, I have one question. That I have one patient that is almost 20-year-old patient. So she has only nodules and like furunculosis like lesions. So as per grading, it comes to grade 1. So if at all she is affordable, can we go to adalimumab along with the antibiotic, or only antibiotic therapy we can begin?
I'll prefer minocycline with rifampicin, could be the best option. For 12 weeks you can give, and then continue only minocycline for further few months. By 12 weeks, the lesions will subside.
Okay. Thank you.
Another thing is, whenever you are giving the antibiotic for long period, please see that lactobacillus is being added to it.
Yes.
Because whenever giving for prolonged periods, so we have to be sure that there are doxycycline tablets which come with a lactobacillus, but somehow minocycline is not coming with lactobacillus as such.
Madam, in HS, before shifting to these antibiotics, for how long we need to see, like before we say it is resistant to particular antibiotic? So for how long, any duration being?
No, actually, I don't shift much more into antibiotics. I start with this 3 line of therapy only, like, start with either doxycycline or minocycline with rifampicin, and then continue with minocycline.
So maybe after 12 weeks of therapy, if they have not responded, then we think it is resistant then.
Yes, but normally that's true.
Okay, thank you.
There are a few questions from the audience, from the delegates. There are a few questions regarding the HS and pregnancy. Isotretinoin and HS is already covered, and regarding the zinc gluconate dose and duration. This is question from Dr. Anuradha Rao.
Yeah.
And
Zinc gluconate and nicotinamide. have been tried actually. Zinc-gluconate in the dose of 90 milligram and nicotinamide in the dose of 30 milligram combination has been tried in a few patients, which have given good results in mild to moderate cases, not in severe cases.
Okay. And role of diet with regards to yeast avoidance. Hello.
Yeast avoidance.
No idea.
Yes, no idea.
Why
And,
should yeast be avoided?
This is a question from the chat box.
That's it. No. I just want to know why should yeast be avoided?
Yeah, I think few diet can aggravate this HS. Probably this could be the one of the yeast also can aggravate it.
Oh, I think we should know about it. I'm not sure about it.
Another question from Dr. Anuradha, how would you define remission? Disease free for how long before you decide to move up to next drug?
6 months to 1 year.
Actually, a patient can have exacerbation even after undergoing remission for 5 to 6 months also. So there's nothing like only what we say the patient has got undergone a long remission. The disease can erupt later on also. And as I said, we don't keep on changing the drugs. It's the therapy remains the same, or we have to, if it is an adalimumab, I can give adalimumab again, or meantime colchicine. So that's what I said. We have to be with the patient throughout his journey. So we only record the patients what he's taking, and then we try to find out last 6 months before which was the best drug, which was there. So it is like, we cannot define. It is that you have to be with the patient with records, and then we to correlate. The precipitating factors could be different at that time, or that's how.
Time will solve the problem, Anand. As the age advances, automatically it will go off. Don't worry.
Yeah, sir. This is another question from Dr. Kavita Kilaparthi. In inflammatory area, which gland is implicated in HS, as apocrine glands or not there, sweat glands?
It's mainly the follicular unit, they say.
Okay.
Pilosebaceous unit. Apocrine is secondary.
Okay. Is the role of low-dose doxycycline, like 40 mg doxy, useful for long term with no ensuing resistance?
I don't think low dose will work.
Low dose, don't try. Unnecessarily, you will be prolonging the duration of treatment. Low dose, never try. Hit it hard. Hidradenitis suppurativa, you should hit it hard.
Right. Okay.
So for starting the adalimumab, in case if you go with early staging, can we directly put them with adalimumab in case of stage 3?
Yes. But after antibiotics.
Rather,
Can I say one thing which we had that yeast and the doubt? Actually, in Crohn's disease, they say that avoiding the yeast will improve because antibodies will be formed for yeast in Crohn's disease. So maybe with that relation, they would have asked HS and Crohn's disease relation with yeast. I think I read somewhere the papers. I'm not. So that is sure that there is antibodies relationship with Crohn's disease with the yeast. So when there is Crohn's and HS, then there is a study that avoidance of yeast has improved the lesions of HS.
Oh, I think we don't know about that, but that is a good question, and we should really thank the person who has asked the question.
Madam, have you found the incidence of carcinoma in HS?
No, I have not found, but I have read I have met, I don't remember the doctor's name. He had treated HS, and he said it is always better to keep in mind the malignancies in the case of HS.
Yeah. Do we do biopsy for HS initially?
Patients, not really, but we should do.
Okay.
In Pune, they do it very often, very regularly. In Pune Medical Pune.
When in doubt, suppose you have a doubt about tuberculosis, abscess, or something like that. Otherwise, usually the clinical picture is so glaring that we know that it is hidradenitis suppurativa. But in case of doubt, it's better to do a biopsy. And especially before starting on biological, it is always better to do a biopsy.
And this is a question from Dr. Aruna. How to do benzyl peroxide wash?
We used to get ready-made benzyl peroxide wash.
Yeah.
Benzyl peroxide soaps are there. There are soaps which contain benzyl peroxide. For acne, we are using them. The same benzyl peroxide can be given. Chlorhexidine 4% soaps are there. Benzyl peroxide soaps are also there.
Face washes are
Face
there.
washes are there.
Yes, sir. Yeah, it's almost like HS with latent tuberculosis already we covered. Dosage of rifampicin duration we covered. Almost like colchicine we covered. All the medications, almost isotretinoin, low dose, high dose, all the questions is the audience as well is already covered. Okay, almost all the audience questions are covered, sir. I think right now time is 6:54.
So I really thank the organizing TSIDL organizing team for giving me this opportunity, and really thanks a lot to all my panelists and the moderator for making me learn so many points today. Really, Padasadi sir, Sharmila ma'am, Poonam ma'am really enlightened me on the pathogenesis, and Sharmila ma'am, you have really taken us through a journey through HS.
Yeah.
Thank
you, Anand, for your nice moderation, and thank Dr. Sharmila Patil. Wonderful talk. I think everybody got enlightened with your talk. And even the pathogenesis also, the madam, I'm not able to remember her name. She also dealt very nicely about the pathogenesis. Yes, she also dealt very nicely with the pathogenesis. And we should thank the company also for organizing this event. Overall, it's a good learning lesson for me also.
Dr. Janardhan and Dr. Satyasri, please take over now.
Yeah. Thank you very much. We have learned so many new things. Yeah, on the behalf of TSIADVL 2022, I thank Dr. Janardhan sir, General Secretary, and Dr. Ramesh sir, President TSIADVL, and Dr. Purnachandra madam, especially for accepting readily on asking. Thank you very much, ma'am. Dr. Sharmila ma'am, Professor and HOD DY Patil Hospital. Ma'am, now we can give Adalimumab without any hesitations, and thank you for enlightening on that. Dr. Anand, for excellent moderation. We have learned so many new points, new treatment options, and excellent cases you have collected. Thank you very much, Doctor. And Dr. Pardasarthi sir, academician and a great teacher at ASI. Thank you, sir. We have learned about interleukin-6 and CRP as these biological markers. And Dr. S.B. Kavita, my long colleague, long-term associate and associate professor, and Dr. Purnachandra madam, professor and ESI Medical College. Dr. Indira madam, associate professor at Osmania Medical College and a great academician. Dr. Rajlakshmi madam, senior consultant and Apollo Hospital. Thank you, madam, for chairing. Thank you both of you for chairing this session.
Indira madam is professor, no?
I think
she has become professor now. That is what I was told. No.
No, sir, I'm still associate.
On paper, madam is professor, sir.
Yeah, on
Because of this.
Professor.
Yes, sir. We know government hospital, government medical colleges, we get very late. And thank you very much, everyone. We have learned very new treatment options, and thank you, Hetero Healthcare, especially Mr. Venugopal and Jayashree and all others who are behind the screen and help to have this great session. Thank you very much.